Hi, this is Terry Kuti, founder and director of Deep Sea Foundation. Welcome to the educational channel where we talk about all topics related to breast reconstruction for those affected by breast cancer. I'm joined today by two amazing surgeons from Midwest Breast and Aesthetic Surgery in Columbus, Ohio. They are two board certified trained plastic surgeons specializing in microsurgery and autologous breast reconstruction for patients who are affected by breast cancer. So I'd like to welcome to the program Dr. Ergun Kochak and Pankaj Tiwari. Welcome, guys.
Hi, Terry.
Hi, Terry. How are you? Good evening to all your listeners and viewers out there. We were going to say that Terry's the boss's interaction, so we're just going to do whatever she says tells us to do.
Okay, I'm down for that. Let's roll. I got a great topic today, and really, I want to thank you both for answering the call to duty, because I did reach out to you and say, hey, do you want to do this video on phase two? Phase two can vary for patients so much. And, first of all, I think patients need to know that breast reconstruction is seldom one surgery. It's not a procedure, it's a process, even in the setting of implant reconstruction. So phase two can be for implant reconstruction, autologous reconstruction using your own tissue. And it can vary so much. I mean, there's different things that can be done depending on if you've had immediate, delayed reconstruction. So, so here's the three questions. This is what I'd like to focus on today. What is fat grafting done for? How long is the recovery? And then, is there pain involved? I can probably address the pain too. I'll throw a bit in there since I've had it myself. So I don't know which one of you want to start, but really thank you for talking about this topic today.
No problem. I'll jump in. So I think those are great questions. And I think, you kind of opened up asking about phase two, and then you jumped straight to fat grafting. And it's interesting because it's probably because fat grafting is, I would probably guess, the single most common thing that we come back and do at phase two. So there are several other procedures that we might perform at that second stage. The good news about the second stage surgeries in general, I'll just say a few generalities before I come back to fat grafting, Terry, is that the second stage surgery is usually a much smaller procedure than the first one, regardless of what the first one was, whether it was placement of implants, tissue expanders, or autologous tissue. The second phase surgeries tend to be outpatient surgeries. They tend to be done so that the patient can come in and go home the same day. And the recovery pretty much across the board is somewhere between, I would say, 2 to 3 weeks in general after a phase two surgery to get back to most activity. And again, not probably to the most strenuous of activities, but to most things, especially like an office job or something. Most of our patients take 2 weeks off before they return. And the other good news is that it doesn't as often, and probably not all, I'd say less often requires or involves a drain. So most people really always fear the drain. And so phase two is nice because it doesn't always, and pretty much usually does not involve a drain. So, but I'll get back to your fat grafting and I'll kind of lead the way and then I'll let Dr. Torrey kind of take it from there. But I think your first question was, when is fat grafting done? Is that correct?
Yeah, and thanks for making the distinction because it's not always done, but yes.
Yeah, so
Yeah,
we have sort of a template for our phase two visits. When a patient comes in at around that 6 week mark after their first surgery, we'll sit down with the patient and we'll go through a long list. I like to call it the menu, and the menu has, I'd say, probably about 12, maybe 13 different procedures that we would commonly use, and they pretty much just have little check boxes next to it, and we just kind of go down and see which ones are necessary. And like I said, I think fat grafting is probably, wouldn't you say, Pankaj, one of the more common ones that we usually do at phase two?
Yeah, I think it's become increasingly more common, and I think the better we've gotten with fat grafting, the better the results are. I think the more long-lasting the results are, and it does a lot to fill in some of these areas of deformity or concavity that you get either with implant reconstruction or autologous reconstruction. So it's really become a mainstay, I think, of a lot of our face suits. Not everybody, but a lot of people get some
I
fat
think it's a
grafting.
little different between the autologous and then the implant. Both of these patients will likely or benefit, a lot of times benefit from fat grafting. But I think in the population of patients who have had a tissue expander implant reconstruction, we're doing a lot of fat grafting these days because there's been a humongous shift in how we do implant-based reconstructions. I'm sure you've talked about this before. I think we've talked about it before on the podcast, but before we would put the tissue expander implant behind the muscle. So there was plenty of soft tissue covering an implant that was, there was muscle and then there was the skin left after the mastectomy. However, now there's been a gradual shift to actually try to put that implant and expander in front of or on top of the muscle. And there's so many great reasons for that. We've talked about it before. It's less painful, better anatomic location. It ends up with more projection, all this stuff. And it's less deforming internally to the body's musculature. So, but because of that, now we've just got an implant and just skin. And so there's not a lot covering that implant. And so now it's become more than ever, especially in implant reconstruction, one of the mainstays, one of the best ways we can increase the soft tissue coverage over an implant is to come back and add fat between the skin and the capsule layer where the implant is contained. If we can go in there and I always tell people it's kind of like icing a cake. So I always make cakes for the kids and their birthdays. And initially you start with this naked cake and you cut it out, and always making fun shapes and stuff. And so it always starts out looking not too great, and there's a lot of bumps and lumps, and there's a lot, exposed. But come back and lay down a layer of icing, suddenly those imperfections go away. And then if you come back a little layer and add another layer of icing, you can really smooth things out. Or even if you put fondant on top of that, you've really won the game, right? It's like perfectly smooth. So I always liken fat grafting to kind of layering icing on a cake. You can kind of get thicker and thicker as you go. And sometimes if you do it more, you can get more soft tissue. But that's for the implant. What do you think, Dr. Tawari, in sort of the autologous scenario? It's a little bit different, wouldn't you say?
Yeah, I love that icing example because it really is, I think, very much like icing. You can layer the fat over time if you need to, and oftentimes someone who's had radiation treatment, one round of fat grafting sometimes isn't enough, and you can fat graft into that area. We talked about how fat grafting can even improve some of the radiation changes, and there's good literature out of Italy, that really shows some changes to the radiated tissue and how it improves with just fat grafting. I think that for the implant folks, like Dr. Kochak was saying, we're really focusing on the upper chest, kind of where the implant stops and the chest wall begins, kind of the cleavage area, basically, or the décolletage. That's a good word, décolletage. It's similar for the patients for autologous tissue, but a lot of times with autologous tissue, it really is like sculpting, and the fat grafting is adding. We always say it's the first phase is getting the clay up there. The second phase is getting the clay fashioned and molded. So you can liposuction the flap. You can add fat to the flap. So you can really, in a very sort of sculpted way, achieve an outcome that is proportional and symmetric, and you can address these areas of baseline asymmetry, whether it's radiation or the patient's own anatomy. So you can go from as much as possible from cousins to sisters or sisters to twins, whatever family analogy you want to use. But it gives us the freedom, I think, with fat grafting to address some of those differences.
And you asked Terry about pain, I think. And so, the actual fat grafting to the chest part, that has really almost no pain whatsoever. I'd say it's one of probably the least painful things we do in all surgery. It's the process of getting the fat for the grafting procedure that is painful. Yeah, as you may be able to recount. And
Well, and just tell them about that cannula.
yeah, so the way we get fat, for your listeners who may not fully understand, we have to get that fat from somewhere. We take it most often from the trunk, would be the flanks or hips area, and up into the abdominal region. A lot of our patients, even if they've already had a deep, they might be full in sort of the upper abdominal area, since the lower abdomen has been contoured and removed. And so those are great areas. And then if we have to keep looking for places, the thighs, the outer thighs and the inner thighs can serve as great donor sites as well. But to get the fat, we do have to make teeny little puncture holes. They're about 2 millimeters, but then we use a liposuction cannula, which is a metal cannula. It's like a straw. It's a metal straw, and it goes to a vacuum pump. And then what that vacuum pump does is we kind of move that straw in and out between the skin and the muscle where the fat lives. It will suction the fat in little tiny globules. It'll suction the fat into a canister where it collects. And then we take that fat where it's collected and we filter it down, and then we get rid of all the extra fluid, and we basically leave purified fat. And that purified fat is then put into little syringes, and we basically just inject it back into the chest. And the goal is to leave teeny little droplets of fat. And that's why it's a little bit time consuming, because we have to be cautious. One of the biggest mistakes that can be made with fat grafting is that too much fat could be laid into one area, and that fat could then end up not grafting. It won't get blood supply, so it could go on to die. And if the fat dies, it'll undergo a process called necrosis. Fat necrosis can lead to hard spots, nodules that can then be concerning. Patients who just had a breast cancer and mastectomy, now suddenly they've got a lump in a reconstructed breast. So that sparks a lot of concern, and then can lead to biopsies and ultrasounds or whatever. And then also it can, as it dies, it can leave little calcifications, little spots that can show up. If we fat graft into a breast, not a reconstructed breast per se, but a breast, that breast is going to be, for example, after a lumpectomy, that breast is going to be having mammograms in the future, and you might see little speckles of calcifications. And remember, cancer also makes calcifications on mammograms sometimes, and so that can be confusing for the mammography. So those are some of the concerns and some of the thoughts that I think people need to understand whenever they're undergoing a fat grafting procedure. But in a mastectomy setting, if they've had a mastectomy, the worry's less, right? Because the breast is gone, and so we're really just fat grafting into skin and soft tissue. So there's really not this concern for breast cancer as it would be if we were fat grafting into a breast after, say, a lumpectomy or something.
One thing I think that's changed a little bit for us in our practice when we fat graft is I think we're able to do thinner and thinner patients. We've been using a system which we've been lucky enough to make a part of our practice that really works great in the thinner patient. It really limits fat loss. I think it's improved our fat take. I don't know what you think, Ergen, but I've been really happy with the lipografter system, and it's particularly useful in the thinner patient who's undergone a gap flap reconstruction or a dug flap reconstruction or a deep flap reconstruction, where you may not have enough volume. It didn't make sense to do a stacked flap in that patient for a variety of reasons. And so fat grafting can give us a fair amount of volume to not only fill in those areas of discrepancy that we were talking about, but also address volume and projection. And I always kind of give the example, if you have a thinner patient, you can still get between 500 and 600 cc's of fat from them. If you're going to the thighs, inner outer thighs, back of the thighs, the flank area. Now, half of that fat on average will go away. So that's about 300 cc's per breast divided by 2. So that's 150 cc's, which is, I think, equivalent in most patients to a cup size change. So I think that's the rough math on how fat grafting can be used to improve volume and improve projection and improve these areas of concavity. But I think the lipografter system has really, really made a difference for our thinner patients who, I think we were maybe more concerned, are we going to be able to get enough fat on those patients in the past?
You guys, while you were talking, brought up a couple of good points. So Dr. Kochak, you said that the fat is extracted from where it lies between the skin and the muscle. And we were talking about pain. I get it now, why there's that pain. And I tell women, to me, I didn't describe it as pain. And because you mentioned that muscle, it makes sense to me now what I was feeling. I felt like I had been to the gym for an intense workout after I hadn't been to the gym for maybe.
I always tell people it's like you fell down the stairs because It's more soreness, deep soreness. Yeah, this is what it's been likened to, and I've been told. Yeah,
Yes, soreness versus pain. And really, it diminishes quickly over, I mean, every day it improves exponentially. And it especially
absolutely.
is helpful if you get up and keep moving. I mean, you have to rest, elevate, wear your compression, garments that you give patients. And I know that varies too, but it really does help. And the other thing, I love the analogy about the icing on the cake. I just made my husband a birthday cake last weekend, and I did that first layer. I did that
Huh.
first layer first. I gathered up all the crumbs, and then I put that other layer on top so it was smooth. And,
Yeah.
I think women are looking for that smooth appearance. You talked about the upper pole. We don't want any, okay, I got an implant right here. Okay, I
Yeah.
have radiation right there.
A shelf.
Yeah, you don't want the shelf. You want that smooth look. You guys gave really good analogies on that. So, what's the
One thing, Terry, I think is important. A lot of patients in phase two are really worried about the anesthesia. They've already gone through a long operation, and now we're talking about a second operation. I
Mhm,
think that it's really important to emphasize that more and more we're doing this in an opioid-free setting. So
mhm.
we really are very, very big advocates of opioid-free anesthesia. And I think it really has done tremendous things in our experience to decrease nausea, decrease vomiting, a lot of those very, very unpleasant experiences that patients have after anesthesia, I think in large part are related to the opioids. And with our opioid-free anesthesia protocol, it's been, I think, a game changer. I don't know what you think, or again, if you've sort of felt the
Oh, I would
same.
say for sure. Yeah.
Is it similar then? Are you using a similar protocol as ERAS, the enhanced recovery after surgery?
Yeah,
Are there
it's a great
similarities?
point. It's similar. We actually found, at least in for some of our patients, some parts of the ARAS protocol were actually unfavorable.
Mhm.
The gabapentin, for example, some people had a lot of not so good responses to. So we've eliminated some of those pieces of the protocol. But I
Mm.
think limiting opioid narcotics has really, really been a game changer for us when it comes to people's post-operative recovery.
Everything you're mentioning too, you guys are such huge proponents of the shared decision-making process. So when
Sure.
I hear about that menu that you go through at the beginning,
Yeah.
you know, offering all the things that you can do, and then, I hear you emphasizing the fact that you really honor each individual scenario because it's different. It's going to be different for each patient.
At this phase more than ever too. I mean, like in the beginning, it's like Dr. Torrey said, there's a little bit of, we got to get clay up there. And so we got to get a workable, moldable thing. But on the second one, I mean, it's really when sort of we got to put the artist cap on and we really have to start to fine tune. I always used to like to say, we can't assume that breast reconstruction is sort of a one size shoe fits all type deal. You really need to custom. It's got to be a custom order shoe or suit. It's got to be you got to really customize the plan based on not just what we see may not need to be done or we think needs to be done, but what the patient I think is also hoping to achieve. Some people are very, very comfortable and happy with the result that we might think could be made better. And they don't want to go through a lot more surgery. And those are the people where we have to be able to, read each other and understand that so that, people are a very much important part of that process and they can actually decide when they get more or don't get more surgery. I mean, it's our job to say, hey, I can do this, but do you want to do it?
Yeah, and I think whenever we talk about phase two, I always like to let patients know that it's covered by the Women's Health Care Act of 1998, that these are parts of the reconstructive process related to the cancer. So patients don't feel like this is something not related to the reconstruction when it so clearly is. But I really want to echo what Dr. Kochek said. This really is um, the part where we put on our artist caps and really kind of get a sense of what the patient wants. What are they concerned about? What are they anxious about? And really drill down on those concerns, because this is the time to make it truly their reconstruction.
Yeah, so I have a comment question about that, Dr. Tawari. It's really interesting that you talk about the artist cap, because to me, I always kind of equate the word symmetry, achieving symmetry. Of course, you do that at phase one, but even more so, I think at phase two, with these revision procedures. So, I think that some women, Dr. Kochak, you brought up the point about the fat grafting. Some women might think, oh, I'm at a plastic surgeon. I'm going to get lipo. I'm going to get a new body out of this. I'm just going to have him suck fat out of places that I don't want, and I'm going to have them and just boom, there they are. That's not how fat works. Someone told me once, think of it like a sponge. You put water in a sponge, and after a while, it won't take anymore.
Yeah. You can only put so much fat into a certain amount of breast tissue. And so, the average, I would say, across most breasts is going to be, depending on the size of the flap or the size of the area you're putting it in. For a flap, we can usually get for, an average size flap, we're somewhere in the 200 to 300 cc per breast. But when you're talking about fat grafting after an implant reconstruction, trying to smooth out the rippling that's visible, trying to thicken that soft tissue coverage, it usually takes a lot less. I mean, there's not a lot of room there. If you think about the amount of space between the skin and the capsule, it's a very narrow space. And it's another, I was actually, while we were talking, I was trying to find a picture I used to have in one of our social media. I came back and took implants out of a patient. We were going to convert their implants to deep flaps, which is something, we do a fair bit. And it was a little surprising when we pulled these implants out. There were tiny little balls of things all the way inside. And that was when the patient had multiple rounds of fat grafting. Whoever had done it had pushed the cannula straight through the capsule and into the implant and put fat graft all throughout the implant itself. And so the implant contained multiple little balls of necrotic fat. And so it is a technique that is a little bit, just again, just like microsurgery, just like some of the autologous tissue stuff. There's a good reason I think a lot of us go on and do after plastic surgery, training, and those are sometimes called a fellowship. It's a really confusing, I think, thing for people. A lot of people wonder if they're getting a fellowship trained microsurgeon, and I don't think that a lot of people are just fellowship trained plastic surgeons. But I think it's very important, when we talk about this type of technique, doing it a lot, doing it in the setting of a breast reconstruction is important, because those are the types of complications that we want to avoid.
Yeah, and
Now, Terry, I will say that, when it comes to the aesthetic piece of the liposuction, I think that's what you were alluding to. Patients are like, well, I'm going to get some liposuction. I do think that there is an element of contouring the abdomen with liposuction. I think there's certainly an element of doing a good liposuction for the patient. You don't want to simply remove, a certain amount of fat and then leave them with a deformity at the leg or the thigh or something like that. So I do think it's really important that we think of the liposuction piece as an aesthetic procedure, and we're doing it for the reconstruction, but in itself, it is an aesthetic procedure, and we have to treat it that way. And so whether it's liposculpting the abdomen or making sure that we take the fat from appropriate areas, whether it's the saddlebag area, banana roll area, medial thigh area, you still want to do a nice liposuction there and not leave them with a problem from the harvest site. So I think it's really important that we think of liposuction as a cosmetic procedure, because at some level it still is.
yeah, I didn't circle back to that because you were mentioning the artistic eye. And yes, thank you for bringing that up. Because don't you guys generally, you look at the entire body. You don't just go, you don't willy-nilly say, okay, well, there's some fat. you look at the woman's entire shape and try to even it out and take fat from different areas that are going to have optimal fat, but also that are going to achieve a nice aesthetic outcome for the second phase.
For sure, yeah. And some people just sometimes really have a particular area that they would really like to have contoured, and it makes it for a very nice opportunity to do that. Because like Dr. Tawari said, I've had so many patients ask me, I say I'm gonna take it from sort of the flank area, and I'll point to one side, and they'll be like, what about the other side? Like, oh, we're definitely gonna do both sides. It's very important to keep it aesthetically pleasing and come out with a great aesthetic outcome, even from where we're taking tissue from.
And
Same
what
with the
you
deep
said
flap, right? Same with the deep flap.
yeah, so important, Terry. Just like Dr. Kochak said for the deep flap, we choose the deep flap because that's where fat is, but not in everybody. Some patients have fat in their thighs, and we're talking about a dug flap. We're talking about a pap flap. Some people have fat in their buttocks. We're talking about a gap flap. So even phase one is really premised on where is the patient's optimal, fat reserves, how is her anatomy factor into her reconstruction. So it really, like you said, it is a whole body evaluation that we have to do.
Yeah, and I know there's probably sometimes, at least it happened for me, just full disclosure and honesty here. One of the least favorite parts of my body are my very thick knees. It's a familial thing. And so I talked to my plastic surgeon. I'm like, hey, can you take a little out of the top of the knees? It all had to do with skin laxity. And he said, I'm not going to do that. If I do, you're not going to be happy. So I think the plastic surgeon also has to be honest. You guys know all about skin laxity and all of that. So, yeah.
Yeah, and compression after liposuction is a very important thing that we have to communicate to patients. We want to address that skin laxity. You want your skin to retract. We'll have patients wear a post-operative garment for 6 weeks post-operatively to help with that skin laxity. So it's the best way to get the optimal cosmetic results from the areas that have been liposuctioned.
Wow, this has been a great conversation. I know we could keep talking, but did I leave out any great questions to ask you both? You seem to cover so much of what I was intending to. Any other last minute thoughts?
I think we've touched on a lot of things, and I think it's a good introduction to sort of what people have come to call phase two. And so we can always go into deeper detail if questions come up. We can always come back if you see that there's any topics that people really want to kind of come back to. We'd love to anytime.
Yeah, if anyone's interested, we have a lot of information on phase two and fat grafting on our website. It's www.mwbreast.com. And we've got post-operative pictures in our gallery, as well as information on the surgery and the post-operative recovery.
Excellent. We're going to put all of that information when we edit and get the video published. And I want to thank you both for joining today. And of course, if you have any questions after you watch the video, leave a comment. We're getting some great comments on the Deep Sea Foundation channel these days. Viewers are asking. So ask the questions, and we'll see if we can get them answered. If you have any other topics that you'd like us to cover, please let us know. Again, thanks to Dr. Ergun Kochak and Pankaj Tiwari today from Midwest Breast and Aesthetic Surgery in beautiful Columbus, Ohio. Thanks for joining today, gents.
Thanks, Terry. Bye.
Thank you, Terry.
All right.